encourage mind to think, enhance to create, and hearts to love. Good morning. I would like to stretch a warm welcome to all of you. I'm Ms. Ruby Singh, Associate Professor of Paral Institute of Nursing. Take the privilege of comparing this webinar. It's my pleasure to welcome you all to this delightful webinar on PCOS challenges in adolescents. As we know, nowadays PCOD or PCOS affected adolescence rate is increasing day by day. Almost 22.5% Indians, they are the sufferer one. And through this webinar, we are going to impart some of the knowledge we are having the specialist and we are having the ma'am, Dr. Shanti Sophia ma'am. She is going to impart the knowledge regarding the PCOC and what is necessary for the adolescents to maintain in order to get rid of it. So, before going to give this mic to the ma'am, I just want to let you introduce what is the PCOS. So, this PCOS is the polycystic ovary syndrome. It is a hormonal disorder which is common in the women of the reproductive age. Adolescents with the PCOS may have the infrequent or the prolonged menstrual period or excess male hormone, that is the androgen. The ovaries may develop the numerous small collections of fluid that we say the follicles and fail to regularly release the eggs. It's a great privilege and honor to welcome our speaker, Dr. Shanti Sophia Ma'am, Professor HOD Obstetrics and Gynecology, Sharda University, Noida. She has completed MSc Nursing and the PhD in the specialty of the OB-GYN, Obstetrics and Gynecology. She has great contribution in the field of the research as she has published many more national and the international papers. She is examiner and the paper setter of the various university. She is dynamic and well informed and passionate about her profession. With these words, I would like to invite ma'am, Dr. Shanti Sophia, to begin her session. Please, ma'am. Ma'am, you are mute, I think so.
Yeah, now I am audible. Hello.
Yeah.
Yeah,
Yes,
yeah.
ma'am.
Thank you, Ruby, for introducing me, and good morning to all of you who are present for the webinar. As already Ruby had told shortly about the PCOS, like it is commonly seen in adolescents and in all the women especially. So now we will go with the a short introduction about what is adolescence, then how PCOS affect the adolescents, and what are the major challenges faced by the adolescent and how it should be managed. So I'm first of all I ask apologize to all of you for making you wait for a long time due to the some internet issues, and I think I will be trying my level best to complete it in time. So first of all, adolescence. So all of you know it is defined by WHO as the period between 10 and 19 years of age that includes significant and critical changes in growth, development, and puberty. So PCOS starting age is normally diagnosed when it is difficult to get pregnant, but it begins after first menstrual period as young as 11 or 12 or develop in 20s and 30s of age group. So challenges during adolescent with PCOS, it prevalent of PCOS in adolescent is 15 to 19 years of age group, and it is estimated to be 1.14% by National Health Indicator criteria. So adolescence is a transitional stage of physical and psychological development which occur during the period between puberty and adulthood. So functional variation in the hypothalamic, pituitary and ovarian axis during puberty leads to changes in reproductive hormones which may mimic symptoms of PCOS. So normally adolescent period, they are from the puberty to adulthood they change. So during that period only the secondary sexual characteristics appear and so many hormonal changes take place. So this occurs in the line, that is hypothalamic. It influences pituitary, and that in turn influences ovarian hormones. Then the symptoms occur. So this may mimic PCOS symptoms. So that is first important challenge is diagnosing PCOS. Then risk of underdiagnosis also is there, because they may think the PCOS symptoms can be misunderstood for normal symptoms of puberty. And third risk is the use of inconsistent, non-evidence-based approaches in the diagnosis and management of PCOS. So these are the major issues in challenges during adolescent. So now PCOS. What is PCOS? It is an ovarian cyst, any collection of fluid surrounded by a very thin wall within an ovary. Any ovarian follicle larger than 2 centimeter is known as cyst, and it may be as smaller as a pea or as larger as orange. So normally every month a woman like a follicle is formed, but if it goes above the level of 2 centimeter, then only we consider as a ovarian cyst, and it should be filled with the fluid. So the cause is, it is normally not known, but it is considered that it may be a combination of hereditary and environmental factors, and other factors are endocrine, and who are living in industrialized area, then socioeconomic status, then sedentary lifestyle, lack of exercise, diet high in meat and animal fat, and high risk milk consumption, and infertile women. So the clinical manifestations are, all of you know, so I'm going little fast. It is one is severe, sudden and sharp pain, fatigue, pressure in the pelvis, breast tenderness, nausea and vomiting, fullness and or pressure in the abdomen, irregular periods, urinary frequency, anorexia, bloating, abdominal girth, and abnormal uterine bleeding or spotting. So these are the clinical manifestations. And classification of PCOS. It is classified under three category. One is functional cyst, and another one is dermoid, and third one is endometrioid cyst. So under functional cyst, it is again Graafian or corpus luteal or hemorrhagic. That is, it occurs during ovulation where egg is not released and goes off after periods. And dermoid cyst, it is non-malignant cystic tumor containing extra cytodermal elements like skin and hair. And endometrioid cyst, it is caused by endometriosis and formed when tiny patch of endometrial tissue bleeds and it becomes transplanted and grows and enlarges inside the ovary. Like blood from the endometrial tissue, it goes inside the ovary and it gets spilled into the ovary and it develops into a cyst. So these are the classification. And there are stages of polycystic ovarian syndrome. So it divided into 4 stages. Stage 1 is, it is limited only to the ovaries, and stage 2, it involves one or both ovaries with pelvic extension, and stage 3 involving one or both ovaries with peritoneum metastasis and outside pelvic or pelvic lymph nodes. And stage 4 is involving one or both ovaries with distant metastasis, that is apart from peritoneal cavity, apart from pelvic organs, it goes into the liver or intestine, like that. So how to diagnose? There is no definitive diagnostic test. So criteria for diagnosis for PCOS is, one is irregular periods or no periods, that is amenorrhea. Then higher levels of androgens, that is hyperandrogenism, shown by blood test, or symptoms such as excessive facial or body hair growth, that is hirsutism, scalp hair loss, that is alopecia, then acne. Then third one is polycystic ovaries visible on ultrasound, scan, like more than 20 follicles on one or both ovaries, or the size of one or both ovaries is increased, that is more than 10 ml of the fluid in the cyst. So these are the main criteria for diagnosis of PCOS. Then investigation. So one is physical examination and another one is blood test. That is, you go for a hormonal level of increased androgens, then glucose tolerance test, then fasting cholesterol and triglyceride level, then pelvic examination for masses, growth and other abnormalities. And the investigation continued. Ultrasound to see appearance of ovary thickness of lining of the uterus. Then the additional tests include blood pressure, screening for depression and anxiety, obstructive sleep disorder, other hormones which may affect periods, that is estrogen, FSH, LH, and TSH, prolactin, hormones related to adrenal function. So these are the investigations done. And what are the other risk factors due to PCOS? So the patient with PCOS, they are at risk of heart diseases and other cardiovascular diseases like coronary artery disease and etc. Then obesity, then Hashimoto's thyroiditis, that is an autoimmune hypothyroid condition in which body's immune system attacks the thyroid 3 times more common in women with PCOS. And what are the differential diagnoses? So there are some symptoms which are similar to PCOS, but it may be of another disease condition. So the left side is the disease condition and right side is the test done for that. Ovarian hyperthecosis. So you have to test total testosterone to confirm this. Then congenital adrenal hyperplasia, it is commonly known as CAH. So you have to check for 17 hydroxy progesterone level in the blood to confirm this diagnosis. And other one is drugs like danazol, androgenic progestin, and you can get the history for this drug usage. Then Cushing syndrome, you have to check the 24 hours urine cortisol level, and pregnancy, to take pregnancy test to confirm. Then hypothyroidism, TSH level is checked, and hyperprolactinemia, prolactin
Sir,
level
please,
should be,
excuse me,
yeah.
ma'am. Sir, please mute it.
Somebody is talking in between.
Yes, yes. Sir, hello. Sir, can you hear?
थियरी एग्जाम नहीं आओ प्रैक्टिकल ये एग्जाम છે प्रैक्टिकल બોલાવો તમને જે યુનિવર્સિટી અથવા એમએલ તા આવવાનું प्रैक्टिकल एग्जाम ને થિયરી માં જે બુક લખી છે ને એવું પૂછશે ત્યાં તમને સામે વાયવા જે
Excuse me, sir. Can you mute it?
प्रैक्टिकल एग्जाम ને વાયવા જે
Ma'am, please continue.
Then, so we were discussing about differential diagnosis. So it is hypothyroidism, you have to confirm with the TSH level, and hyperprolactinemia, you have to confirm with the prolactin level. Then adrenal tumor, you have to go with the DHEA, yes, that is dehydroepiandrosterone sulfate. So you have These are the differential diagnoses which mimic the PCOS syndrome.
आपको नाम
And the right side, the
एलईडी जाओ
relevant lab tests are given, which to confirm the differential
આપણે આટલા
diagnosis.
ટાઈમથી આપણે જોયા વગર મોકલું તો એમને જોયું
Then,
નથી.
what are the major challenges to adolescents? So we have seen now the short PCOS. So now the challenges to adolescents are, one is menstrual irregularities, and second one is hyperandrogenism, and third one is obesity and overweight, and fourth one is psychological problems. These are the four major issues which adolescents face. So major challenges, one is first is menstrual irregularities. In this, anovulation or oligo-ovulation, DUB, that is dysfunctional uterine bleeding, and infertility are present. And many experience menstrual irregularity, especially in first 2 years after menarche. And abnormal intervals, that is below 20 days or above 90 days, it requires investigation. And 20% of patients present with normal bleeding in PCOS. So apart from the 80% are will be having the menstrual irregularity. So due to this problem, oligolation or more, irregularity, it is embarrassing because of unpredictability and painful due to infrequent occurrence, often lead to heavier blood flow and increased cramping. And this leads to decrease in blood hemoglobin, altered CBC, which leads to fatigue, weakness, insomnia, disturbed lifestyle, stress, unable to work, misunderstanding at home and office, and conflicts. So this is the challenge faced by the PCOS patient with menstrual irregularity. And second one is hyperandrogenism. It is growth of hair on women in a male pattern, that is in upper lips, chin, chest, upper abdomen, back, etc. And this is to be distinguished from hypertrichosis, which is characterized with clitoromegaly, deepening of voice, which are not of PCOS. And hirsutism, moderate to severe acne, are considered as a diagnosis for PCOS. And alopecia is also a sign, but it is not moderate in adolescents. Then third one is obesity and overweight. So upper body obesity is the key symptom of insulin resistance, but not a required diagnosis for PCOS. But 35 to 50% of patients are obese in PCOS, and obesity and overweight is caused due to decreased physical activity, lack of exercise, sedentary lifestyle, dietary habits, and all this contribute to increase in weight. And it is estimated that women spend 34 hours per week in watching television, which contributes to obesity and overweight. And fourth one is psychological problems, that is emotional well-being is affected in PCOS. So that is depression and anxiety, body dissatisfaction, eating disorders, diminished sexual satisfaction, lowered health-related quality of life, bipolar disorder, and obsessive compulsive disorder. So these are the major challenges to adolescent with PCOS. Now, how to manage this PCOS in adolescents? So we have seen the major challenges. So we have two steps. So step one is the main issue is diagnosis. Already initially we discussed that diagnosing PCOS is very difficult and there is no definitive diagnostic test for PCOS. So we have to go with the physical examination and the ultrasound and pelvic examination. So normally patient comes with history of irregular menstrual cycle and they will have a complaint of hair growth under the chin, and on examination you can see acanthosis nigricans found, that is the darkening of the in the neck. And step 2, so first you have to see this, take the history and get the complaint and examine the patient and diagnose for PCOS. Then second step is go with the detailed history and examination for differential diagnosis. So you have to understanding the link between obesity, insulin resistance and PCOS. Then you go with the medical management towards long-term risk associated with IR, that is insulin resistance. Then management varies over time as the patient enters different stages of life with different goals. So due to long-term health implications of IR, the importance of lifestyle modification towards weight management and maintaining adequate physical activity should be emphasized. So two steps: first you diagnose PCOS, then you go with the history and you have to confirm with the differential diagnosis whether it is PCOS or some other disease condition. So these are the main two steps in management of PCOS. Firstly, understanding the link between obesity, then you go with the long-term management of insulin resistance, then along with the lifestyle modification and weight management. So then in the management itself, the laboratory evaluation, so you go with the clinical manifestation of cardinal symptoms. Already what all the 4 cardinal symptoms we have seen, and go with the pelvic ultrasound, which is 99% specificity is there for the diagnosis. So proposal of any 4 classic symptoms can go with the pelvic ultrasound. That is, the 4 cardinal symptoms are menstrual disturbances, hirsutism, acne, and anovulatory infertility. So if these 4 you find, you can directly go to the pelvic ultrasound for ruling out PCOS. And these symptoms can be both in nuisance and significant health risk. So management can be done under 4 components. So it is divided into 2. One is acute and chronic. Under acute, you have 3 components. Again, that is menstrual irregularity, hirsutism, and infertility. In chronic, you go with the insulin resistance syndrome. That is very important. So menstrual irregularities. Management is normally they give oral contraceptives and periodic progesterone withdrawal. Uh, okay. Periodic. And third one is lifestyle modification and weight loss. Then fourth one is metformin. This is the line of treatment in menstrual irregularity. But before giving oral contraceptive, you have to find out the any contraindications are there, and you have to go with the lipid profile test before giving oral contraceptive. And other things, periodic progesterone also you have to check with the any contraindication is there, then you have to start. And hirsutism, so you go with the biochemical and mechanical management in hirsutism. So what is biochemical? So one is decreasing testosterone production, because hirsutism is hyperandrogenism. So androgen means that is a testosterone, that is the male hormone which is produced more, which gives rise to the male characteristics. So we have to increase the action. So these are the 2 main major thing in the biochemical management of hirsutism. So decreasing testosterone production, you give OCP, metformin, and lifestyle modification. And decreasing again testosterone action, you give anti-androgens. And mechanical, you give, that is plucking, shaving, what normally people go for it, laser, electrolysis, waxing, using hair remover cream. So many things are there. So that can be done for temporary basis. And laser and electron, that can go for a permanent thing. And next one is obesity. Obesity, I think obesity is caused due to the uh, weight loss, overweight. So in a study, Uh, 82% patients with oligomenorrhea they lost more than 5% of initial body weight on a 1000 kilocalorie per day low fat diet over 6 to 7 months, and they have improved in menstrual function. And metformin therapy showed to induce resumption of normal ovulatory menstrual cycle in 40 to 50%, and the dose varies from 500 to 1000 milligram twice daily for 6 months. And we are going with ruling the insulin resistance in this. So because of central role of insulin resistance in PCOS, it is important to improve the insulin sensitivity, which can restore normal menstrual function. So this is as treating the root cause of the problem rather than simply using oral contraceptives. So this is the main thing. And the effect of metformin and lifestyle modification on weight loss. It leads to increase in SHBG, that is sex hormone binding globulin. Thus, it decreases bioavailable free testosterone in blood, and it leads to lowering testosterone action, and it reduces in turn effect of hirsutism. So weight loss leads to decrease in hyperinsulinemia and hyperandrogenism, which in turn increases menstrual function and infertility and decreases hirsutism. So these are the uh, treatment under weight loss. And for psychological problem, we have to go for a behavior modification, reduction of psychosocial stresses, social support from family, peers, and you have to go for a psychological counseling, yoga therapy, and acupuncture therapy, and Reiki. There are so many things are available, alternative therapies. And other things are like premature puberty, that is appearance of pubic hair before the age of 8. It may be an early sign of PCOS and is associated with ovarian hyperandrogenism and chronic anovulation. So this should be identified from the age of 8 onwards, so that you can prevent early PCOS. So increase the awareness of PCOS and diagnosis at early stage will help us to reduce the problems and challenges faced by the adolescents due to PCOS. So all the above diagnostic and therapeutic issues, it applies to adolescents with PCOS. And other one more thing, women with seizure disorder, that is epilepsy, they also should be monitored for PCOS, as epilepsy, it has an influence of hypothalamic and pituitary axis. So with this, I conclude my topic. And a common therapeutic option, that is in short, I can say first one is lifestyle intervention. So that includes weight loss, physical exercise, nutrition modification, and combination of all the above. And second one is local therapies, that is laser, electrolysis, other methods, shaving, waxing, bleaching, etc. And third one is metformin tablet. And fourth one is anti-androgens, that is spironolactone, flotamide, finasteride. And fifth one is oral contraceptives. Again, it is um, low androgenic effect and products with anti-androgenic effect. And sixth one is combination of any therapy. So these are the main things you can follow with in management of PCOS. So in short, I will go through. PCOS was described first in 1935 by Stein and Leventhal, and it is a syndrome manifested by amenorrhea, hirsutism, and obesity associated with enlarged polycystic ovaries. It is heterogeneous disorder characterized by excessive androgen production by the ovaries that interferes with reproductive endocrine metabolic function. So it is amenorrhea, obesity, and hirsutism. Again, this all be discussed. And one is Rotterdam diagnostic criteria. Again, polycystic ovary, excessive androgen, and anovulation. And incidence we have seen. Causes. This is a pictorial. This one, like pituitary gland produces LH and FSH, and excessive obesity leads excessive insulin, and that again influences pituitary gland producing LH, increased LH and decreased FSH. Here granulosa cells, insulin resistance, again it affects granulosa cells, and theca cells are affected, and it increases androgen excesses, and follicle is arrested, and androgen excess leads to hirsutism, and follicle arrest leads to anovulation, and that causes infertility. So this is the pictorial. And this is the pathophysiology again. Insulin resistant with resulting hyperinsulinemia that leads to hypothalamic pituitary ovarian axis abnormality, anovulation, then androgen excess. So this is again one more picture. So you can understand from this polycystic ovary, the arrow marks are given. It influences pituitary, and pituitary in turn influences pancreas, then liver, then release of free fatty acids, which leads to obesity. So amenorrhea, oligomenorrhea, irregular uterine bleeding, infertility, and symptoms: hirsutism, acne, alopecia, baldness, and symptoms of insulin resistances, acanthosis nigricans, and obesity. And these are the symptoms. One is hirsutism, acne, and baldness. And this is acanthosis nigricans. This is the dark patches around the neck, pigmented. So long-term risk: diabetes, heart disease, hypertension, dyslipidemia, endometrial cancer, breast cancer, recurring pregnancy loss, and ovarian failure after surgery. So this is again same thing, hormonal changes, androgen, how it affects, and psychosocially, how the people are affected due to body image, self-esteem, depression, and anxiety due to hirsutism and obesity. So these are the picture. This is ultrasound, and this is the cyst which is seen, and this is the treatment. So obesity, again we have discussed everything. So don't neglect any person with obesity, or anyone who comes to you with the ovarian problem, or a menstrual problem, or whatever it is. So I hope so this is the next time when you see a fat young girl, don't criticize, because she might be in need of medical help. Is she gaining weight rapidly? Is she troubled by facial hair acne or irregular periods? If she is married, why can't she become pregnant? So she may be a victim of PCOS. So you have to, please don't criticize anybody, but try to help them by finding out these signs and symptoms, and counseling them, and guiding them for the right diagnosis and treatment. Thank you.
Thank you so much, ma'am, for the extraordinary webinar. In the beginning, we found some of the difficulty just because of the connectivity issue, but anyhow, ma'am has completed her task. The webinar is completed one. So, if anyone is having any query regarding the topic, they can ask. If anyone wanted to know anything more. Okay, ma'am, I have one question. What do you want to impart the adolescents? Like, what you want to convey the message through this webinar to adolescents?
Yeah, through this, adolescents should know their menstrual irregularities, and they should not feel ashamed or to talk about their menstrual irregularity, because normally people don't come and talk about it openly. Either they should express the problems with, like if they have a facial hair, they directly go to the beauty parlor for waxing. They think they are not going for the investigation or treatment. They are going to the beauty parlor. They think it is normal, everybody are having hair, so I have to do hair removal, or they use cream, or they go for threading or whatever it is. But they should not do that. They should go to the doctor first, and they should rule out what is the problem, why they are having a facial hair. If they are having hair in the chin or upper lip, anything, normally I have seen girls going to the beauty parlor only rather than going to the doctor. So that should be ruled out. And they should not go with a lot of junk food, because that fat gives rise to PCOS. And if they have less bleeding, they think, okay, I'm very happy, I don't have bleeding, I can roam around. But it is not so. Like some people, 2 months, 3 months also, they're not getting bleeding, they're not going to the doctor, or neither they are telling to the parent. So they should tell to the parent that I'm not getting my regular periods, or it is not that amount of bleeding and number of pads. Even the mother should be noticing how many pads they are using, whether they are having pain. Dysmenorrhea means they just go with some anti-inflammatory drugs or whatever it is. They should not. They go for injection, Buscopan, something metacin they take, or go with the hot water bag. But they don't go for the treatment. They don't go to the doctor for any investigation. So I advise all of them, like please, if you have any problem, if it is continuous persisting, then you should go to the doctor, talk to the senior or your teacher, or anybody, whoever they are comfortable with, and they should go for the treatment. So this is the advice I can give. And psychological problem, and the family
So
members
much more. Thank you
and
so
the
much,
peer.
ma'am, for this valuable.
Yeah, and they should support also, no? Even they should not tell, this is a normal
Must say,
period, I also had a period. Yeah.
I must say, those who are the part of this webinar, they could benefited with this because ma'am is motivating everyone. If anyone is having any kind of the symptoms, they approach to the physician, to the doctor before going to go for the beauty parlor or using any beauty cream. So directly have to go for the doctor and identify what the actual situation due to which you are having such kind of the symptoms. So thank you, ma'am. Now is the time to vote of thanks. I extend my vote of thanks to Dr. Shanti Sophia, ma'am, as she has given time for this webinar from her busy schedule, as she is always busy, but she has just imparted with us the knowledge. And I just extend my vote of thanks to the Parul University, as due to which I am here to host this webinar. And I extend my vote of thanks to Principal Parul Institute of Nursing for valuable guidance. And I extend my thanks to everyone, those who are coordinating this event, those who are supporting this event. For around the clock, they are with us. We have the successful webinar. Initially, we had the hurdle just because of the network issue, but still we completed the webinar. And ma'am is imparted such kind of the knowledge that could be beneficial for the each and everyone. Thank you, ma'am.
Thank you, Ruby. Thank you.
And
So I can leave the meeting?
yeah, ma'am. Sure.
Yeah, thank you.